evening, everyone, and thank you very much for joining us. I'm aware that for some of you, this may be your first time, so kindly ABL facilitate our Zoom support group sessions. These are for people that are considering for surgery or have already met our team and are waiting for surgery. It's just a way to touch base with us every month. And the team from Salford all take turns to present different topics. So if there's things that you were hoping would be discussed, you may find that on another session, another time. We do have recordings of the sessions available as well. So you can look at those. And I believe there's a Facebook group as well. So if we can get those links in the chat tonight, we will. But if not, because Stevie isn't here tonight, we'll make sure it's on the next session. So first of all, I wanted to talk a little bit about your journey to us at Salford. So for many of you, you've been referred and you're part of your weight management team, which is why you should all be here this evening. And you will be doing a programme with them in readiness for surgery, or maybe considering surgery, and there may be other weight loss mechanisms that you'll follow instead. So we're hoping that you have as an informed choice as possible, get a feel of our team by seeing us at these sessions. So eventually, and I do mean eventually, with delays and the demand for bariatric surgery, one thing you do need to get used to is long waits, I'm afraid. So from completing your tier 3 weight management, now we use these words tiering, it's just all to do with funding, I'm afraid. So a tier 3 weight management service is the service you're in right now, so it's your weight management service. And then tier 4 is the bariatric surgery service, which is the one that you would be referred to, and then funding would be granted, and then you would come and meet our team to assess suitability for surgery, which for the vast majority is the case. From referral to meeting our team, it can be around 10 to 12 months at the moment. That's our waiting time. But we share everything so that you're aware of what's going on, and I'll give you updates as we go along. So hopefully we'll eventually get to meet you. And when we do, you'll have a letter, and it will have lots of information. So you'll get an email education to start with. So there'll be videos, there'll be some links for all the booklets and patient information we want you to have, and a little checklist of everything we think you should know before having bariatric surgery. And then you'll have a look at that, and you'll be invited to a Microsoft Teams session, which is a lot like this, but it's a bit more personal with much smaller groups, where we encourage lots of questions, and myself and the dietitian will be there to answer all your questions and talk a little bit around the surgeries in more depth. And then usually the week after, you actually come face to face for your appointment with your medic and your surgeon. You'll come along to the diabetes centre at Salford Royal, you'll have your bloods taken, you'll have your weight done, you'll have your observations done. Always bring something to drink and perhaps your phone or a book to read, because we hope you won't be having too many delays, but you'll be there for about an hour and a half. You'll meet your medic. So it's a good idea to bring with you an up-to-date repeat prescription, so that you're not trying to remember everything off the top of your head. And anything that you think might be relevant that you'd want to share with them from perhaps other consultants that you're under. And they'll do quite a thorough one-to-one session with you about your medical history. And they'll also give you an opinion of which surgery they think might suit you as well, and talk you through those. But then in more detail, you'll have you'll talk through the surgeries with your surgeon. So you meet your surgeon in the clinic, and they'll go through a few things with you, and again give you the benefit of our expertise on which surgery we think would suit you. However, if you're very set on a certain surgery, as long as you understand the risks that may be increased in that choice, and your surgeon is happy to perform it, we do absolutely advocate patient choice, but we want you to make that as good a decision as you can with the benefit of our knowledge as well. And then from there, there may be a few more things that you need to do. So most people would have a psychology session. So this is an assessment. It lasts about an hour and a half. it kind of looks at where you've been, where you are now, and where you're going to be, and thinking about a mental toolkit for all the things that life throws at us. And obviously with bariatric surgery, it's very much a surgery that is body and mind. So that's why we are very lucky to have our psychologists. These assessments are not there to catch you out at all, but they're a really good tool for self-awareness and going through this journey. So you have your psychology appointment, and then we may also need you to do a sleep study. This is looking for a condition called obstructive sleep apnea, which is a fancy term for basically having an absence of breath during the night. And your body's saying, oh, you've not breathed, wake up, take a deep breath. And that means you never truly get a full night's sleep. So it's a little bit like having a newborn baby. You wake up in the morning and you're exhausted, even though you think you've been asleep all night. So we test for that condition, not because it would stop you having bariatric surgery. In fact, bariatric surgery is a wonderful cure for this condition, but just so our anaesthetists are aware. And then if there is any treatment that you could have in the meantime that would improve your quality of life, it's well worth doing that study for you. Anything else that we want to ask, maybe if you've got any significant history and we want the opinion of your teams that are involved in that, we'll ask them for some information, and then you'll proceed to the waiting list for your surgeon. So at the moment, waiting times are starting to kind of transpire. So far you've had a lot of information going, look, I'm ever so sorry, we have to be vague, we've got really long delays, we've got really long lists, and we've got nowhere to do our surgery, we're only getting a trickle of activity done, so it could be a year, it could be 2 years, it could be, and so on and so on. Luckily for us, and I think we are the only bariatric surgery team in the north that have been able to get elective surgery back up and running. So we are now doing 2 elective lists per week, and we're also using a private provider to try and clear our backlog. So our backlog starts from 2019, people that have been waiting from that time when it all shut down in March 2020. We do still have long waiters that we're hoping will all be cleared and done with by the summer, and then we can start making dents into our other waiting list. So hopefully in the due course, your secretaries will be able to give you a better idea of how long your surgeon's waiting list is looking. So that's a kind of coming to meet the team, the delays and everything in a nutshell. But tonight for our topic, we have Dr. Waseem Majeed, who is our wonderful bariatric physician. He's ever so knowledgeable and he's chosen one small topic out of all the things that we can talk about when it comes to bariatric surgery, the GLP-1 antagonist. So he'll reveal all about that now. Thank you.
Okay, Jodie, thank you for that introduction. It is nice to meet you all. So I thought I'd simply introduce myself first. So my name is Waseem Majeed. I'm one of the consultants. I work as an endocrinologist, primarily, but I'm also involved in the bariatric side of things at Salford. So I'm sure that I'll meet some of you all in the future when you get referred on to our service after completing your tier 3 journey. So as per my talk this evening, I thought I'd speak about the GLP-1 agonists. So I'm sure that some of you have heard of Saxenda and other agents which have gained some media attention regarding its use for weight loss purposes. So I thought I'll discuss this in a bit more detail and hopefully demystify this sort of treatment option moving forward. I must say that is a very restricted treatment currently in the NHS for a variety of reasons, including funding, but it is an aspect of obesity care that I envisage improving over the coming months to years. So I thought I'd just talk about where we are with it currently. So let me share this presentation with you see how we get on. So I hope everyone can see that. If you are unable to, then okay, good. So I can see some hands moving. Fine, good. So Jody, if you find that my sort of slides are moving, then do let me know if that's all right. Okay. Okay. So let's start. So in the first instance, I thought about discussing what these agents actually are. So your GLP-1 hormones tend to promote what's called the incretin effect. So if I were to summarize this, when you eat, your body needs to process this food. So it needs to digest it, and it needs to activate certain hormonal cascades, which will then instruct the body to simply process this food, let your pancreas know that it needs to make insulin, to digest the sugars and the carbohydrates essentially that you eat. Now, in some patients, so those who are obese, and certainly those who've got type 2 diabetes in particular, what we found is that the level of your GLP-1 hormones, as well as the incretin effect, is reduced considerably. And this impacts the way that the body tends to process sort of carbohydrates. This is a relatively generalized description of how the incretin effect works and the role of sort of GLP-1 agonists. And what we do know is that this is a very early and nascent field, and the true effects of GLP-1 essentially are still to be fully sort of elucidated moving forward. Jody has a hand up. Is that an accident or?
Yeah, no, I wanted to just ask, is there any way on your display setting you can make your slide just so it fills the screen more rather than having the next slide available? Only because we can't really see your little picture very well.
Okay, so I don't know how to do that.
Well, don't worry if not, because I can see that the next slide look like that there's less detail. But
so can I ask you a question? So are you seeing a full slide, or
no,
are you seeing a
half
black
the
screen
has your slide, the current slide.
Yeah.
Then the next half of the screen has the next slide.
Oh no,
any
no.
notes and our pictures.
No, so that should just be for me. So I'm going to stop sharing if that's okay, and hopefully I can share it. Try this again. So let me stop sharing this. Okay.
Lots of people are saying in the chat that you can actually zoom in. So if we don't rectify this, oh no, you have. Brilliant.
Is it working now?
Yeah, that's perfect.
Okay, good.
Thank you.
Fine. Okay, fine. Good. So yeah. So let's move on if that's all right. So yeah. So what we find essentially with the use of GLP-1 agonists, which is usually either a daily injection or a weekly injection, is that it works by reducing appetite. You feel less hungry. There is a more gradual process by which food is sent through your gut, so that the whole digestive process is more regulated, and the and this then results essentially in your body being able to process carbohydrates in a far more in a far more sort of effective fashion. And we also know that patients can feel full a lot quicker, which then has an effect on weight loss, etc., and so on. And there are other mechanisms involved as well. So I'm sure that some of you who may have done your own reading into obesity will have heard about the concept of the neuro-gut axis. So your brain has a connection with your gut, with multiple hormones and good bacteria, as we call it. And we feel that the use of GLP-1 also has an effect with regards to regulating your neurogut axis. But as I said, this is a field that is in the early phases of study, and I expect to know much more about this essentially in the coming years as research tends to progress. Okay. What I will mention here is that the GLP-1 agonists have been on the market now for a number of years, and they've been highly effective for patients with type 2 diabetes. So this is how the agent was initially, or how these agents initially gained popularity. What we then noticed was that it also had an effect on weight loss. So patients with type 2 diabetes have regularly or commonly been put onto these medications, essentially, not only to improve their diabetes control, but as a side effect of the medication, if you want to use that phrase, essentially, also experience quite significant weight loss. So since then, there has been a couple of landmark studies which have explored the use of a GLP-1 agonist for an obesity indication. So can we treat obesity with this? So the initial paper was published in the New England Journal of Medicine. So for those that aren't medically based, essentially, New England Journal of Medicine is a top tier journal. So if something gets published in the New England Journal of Medicine, then it's considered a relatively landmark type of study. And what was published back in 2015 was the use of something called liraglutide. Some of you may have heard of Victoza, which is a daily injection that has been used for many years, essentially to treat type 2 diabetes. And what they did was they doubled the dose. They increased the dose up to 3 milligrams daily. And what they found, and they did this in patients who didn't have diabetes. So they simply recruited patients who had obesity. They also recruited a sort of an equivalent bunch of patients who were given sort of no treatment at all, apart from what they were already on. And they gave one half of this patient cohort Victoza at the higher dose, and they gave the other patients essentially lifestyle advice. Now, what I must mention was that the patients who also had this drug had lifestyle advice as well. So they had both Victoza as well as lifestyle advice, whilst the other group simply had lifestyle advice only. So what they found was that there was a significant reduction in weight in the group that had both lifestyle advice and the drug, as opposed to the group that only had lifestyle advice. So whilst there was some weight loss in the lifestyle advice group as well, obviously as such the significance was seen with the drug alone. They conducted this study over 56 weeks. And you can see here essentially that weight loss was sustained whilst on treatment up until this particular point. This graph below here essentially shows that some or the vast majority of patients had greater than 5% weight loss from their baseline, but there were a small but significant cohort of patients who had up to 15% weight loss essentially from their baseline weight. So it was an encouraging piece of work that was conducted and opened our eyes to the possibility that this was a useful treatment for obesity essentially moving forward. So things have moved on since. So the same company essentially has also made a weekly injection called semaglutide. I'm sure that some of you may have heard of Ozempic, which is the brand name. So this is a weekly injection that has been on the market now for a few years to treat patients with type 2 diabetes. And it is highly effective in terms of weight loss for these patients as well. So again, the company thought, well, why don't we have a look and see if it is effective for patients who don't have type 2 diabetes? And along very similar lines, essentially, what they found was that in addition to lifestyle advice on its own, semaglutide had quite significant, essentially, weight loss benefits as well. What I will mention here is that the dose that they use was a lot higher for obesity, but sort of anecdotal experience also says that even on the diabetes dose, people do experience significant weight loss per se. So on this note, I'll simply move on. So I'm sure that everyone on the talk essentially will be wanting to know if this is a treatment that they could have. And unfortunately, at the moment, it is quite restricted in terms of availability. As I mentioned, there are a variety of factors for this in a practical sense. However, NICE guidance has obviously come out over the past few years. Let me explain to you as to what NICE is. So NICE stands for the National Institute of Clinical Excellence, and it is a body that looks at all the evidence, also looks at the cost effectiveness of a particular drug, and makes recommendations to clinicians essentially, and gives us guidance with regards to who we can actually prescribe this to. So that's on an abstract basis. But then thereafter, local funding and local funding pathways essentially need to be agreed so that a particular patient can receive a recommended treatment per se. So this is simply the NICE guidance. So what it says is that it can be prescribed for certain patients who've got a certain body mass index threshold. They have evidence of obesity-related complications. So, so what we term as being impaired glucose tolerance, or non-diabetic hyperglycemia, as they call it here. They have sort of high risk of cardiovascular complications. They have a history of hypertension. They have a history of hyperlipidemia, etc., and so on. So what I mean by sort of dyslipidemia is if you've got raised cholesterol levels, and it must also be prescribed by a specialist service who have the capacity to be able to monitor these patients, and it is something essentially that patients usually tend to have for an initial scope of 2 years. what I will say here is that there is a reason as to why they've excluded type 2 diabetes as an indication, and that is because these agents can already be prescribed by your local GP for a diabetes indication. So if you've got type 2 diabetes, for example, and obesity, then I would expect all of you to be on some sort of GLP-1 agonist, whether it is Victoza or semaglutide. And if you aren't, then it is worthwhile for you to have a conversation with your GP about getting you onto this particular treatment. And it doesn't really, or rather, it can be prescribed even though your HbA1c, which is a marker of your diabetes control, is good. Okay, so it's something that you may wish to look into if a patient has obviously got type 2 diabetes. When a patient gets put onto a GLP-1 agonist, we normally advise that they need to adhere to the dietary guidance given by your local dietitian as well as your nutritionist. We recommend that you calorie restrict to approximately 1400 a day. This is mainly to avoid patients from experiencing adverse gastrointestinal side effects, so things like nausea and diarrhea. And eating less essentially tends to minimize this risk. Usually, GI side effects tend to resolve the longer you have it. So it can be bad, can be problematic in the initial phases of your treatment, but if you're able to cope with it, etc., then the side effects tend to improve or go away. The recommendation also says that you must lose 5% of your body weight by 12 weeks on the full dose, and if this is not achieved, essentially it is deemed that this particular treatment for obesity has failed, and therefore we discontinue it, and each patient essentially is only eligible for a 2-year treatment course. So I thought I would also discuss about how we use these agents through our service simply for an obesity indication. So currently it is primarily used in the tier 4 service. So what happens is after you complete your tier 3 program, your local weight management program, and get referred for bariatric surgery, and sort of when you see us as well as your surgeons in clinic, there are some patients who are still so overweight or who have got a body mass index that makes bariatric surgery technically challenging. So, so if we do have such a patient, then so in addition to fulfill the NICE criteria, etc., we put them onto this treatment to try to get them to lose weight so that they can be at a body mass index threshold to safely go ahead with surgery and obviously get the best outcome from it. And that's more or less a whistle-stop tour, essentially, of sort of GLP-1 agonists for obesity indications. So the 2 brand names currently are Saxenda, I'm sure you've heard that, which is the daily injection, as well as semaglutide. This is classically referred to as Ozempic for patients with diabetes, but the company that has made this drug essentially is also coming out with a brand especially for weight management indications, and we haven't really heard about the final NICE guidance for use of the weekly injection yet. So So in summary, Saxenda, which is a daily injection, has been approved in restricted circumstances for use for an obesity indication alone. Semaglutide, which is the weekly alternative, has been approved in an abstract sense, but the final NICE guidance is still to be released, so we don't have access to that on an NHS level just yet. So that's my talk. I'd be happy to answer any questions.
Thank you very much. So thank you so much. It's such a topical topic to talk about, and I saw lots of questions going along. So I'll just give you a little overview of how I see it as the nurse, and who often I get targeted with all the different weight tablets and different spices and other kind of interesting things that may help you with weight loss, which generally really doesn't. So when this, as I called it, the skinny injection, came about, we realized as a team, and the science community have said that this is something that can give meaningful weight loss. However, we're not there yet. We wanted people to be aware of it, especially if people have type 2 diabetes. This is something you could perhaps already access if you kind of it's not going to be a risk to you, and that's something you can discuss with your GP quite easily. If you're asking for these injections as something as a means of weight loss on the NHS or through your tier 3 or tier 4 weight management services, there simply aren't the funded pathways in place yet. But it's important that we do talk about it, because I think lots of people have got questions about it, and I also think for some of you this may be the first you've heard about it. Already, the way that they've put this to us as an NHS to be used, even though we haven't got the funding pathways to use it properly yet, even though we know it exists, they know that they would only ever let somebody have it on the NHS for 2 years. And unfortunately, the way this antagonist works is when you're not on it, you would weight gain again. So it would be a very expensive thing to do privately for the rest of your days. And bariatric surgery is still absolutely the means of meaningful weight loss long term. However, if I had an ideal scenario, that it would be something that us as tier 3 and tier 4 weight management services could provide you whilst you're waiting for bariatric surgery to help with some meaningful weight loss. So it's something to be aware of. It's something that we're all fighting for behind the scenes to try and make available to everyone. I think the slide that might be worth putting back on at some point, if that's okay, Waseem, would be those NICE criteria that you could discuss with your GP, because some GPs will say right now, no, there's nothing. Our local CCG, the authorities that dish out money.
Can I simply cut out there? So I just wanted to make this very clear, if that's okay. So I was simply talking about an NHS service, and there is not much point essentially in patients sort of approaching their GP about Saxenda, because they aren't allowed to prescribe it even if a patient fulfills the criteria. So it is something that can only be prescribed for an obesity indication alone through a weight management service, so a tier 3 weight management service, usually with doctors who have the expertise to be able to monitor these patients. What I should also say is that if you've got type 2 diabetes, right? So if you've got type 2 diabetes as a diagnosed condition, then you've got access to GLP-1 agonists, not necessarily Saxenda, but certainly you have access to Ozempic through your GP, and it is listed as a green drug. So you don't have to get approval from a hospital diabetologist, for example, for a GP to prescribe a GLP-1 agonist if you have already been diagnosed with type 2 diabetes. And that's the reason as to why type 2 diabetes is not part of the selection criteria that NICE have sort of approved.
Right. No, I'm glad you cleared that up for us, because seeing a lot of the questions, I think a lot of people are thinking, oh, there's something there, but it's not there quite yet in terms of NHS, but obviously it's something that is out there and we want people to be aware of it. So I'll go over to you, Grace, who's kindly had a look at some of the questions, if we haven't answered that one already for people.
Perfect, thank you. Yeah, there's a lot of questions about eligibility in the chat box, so thank you for clearing that up for us. Oh, I've just lost the question I was going to ask. Oh, someone said, in the future, will there be a session on sort of post-surgery and vitamins and things like that, going through the diet after surgery and things, because that's what they'd like to know.
Yeah, absolutely. So we have our pharmacists come and do a talk, which is really interesting because they talk through perhaps medications you're already on and how to have them in that liquid phase of your diet. And then, as with all bariatric surgery, sleeve and bypass, you will need to have multivitamins for life, some of which your GP can definitely prescribe. The only one that they don't have to is the multivitamin. So it's just worth being aware of that, because that potentially could be a cost to each month to get A to Z complete multivitamins after surgery.
So I was just having a look through some of the questions that I thought I'd just go through them, if that's okay, because there were sort of some with a sort of unifying kind of theme to it. So first of all, if you gain access to Saxenda for weight management purposes, essentially simply for an obesity indication, that does not mean that you are automatically disqualified from having your bariatric surgery. So I don't want that to be confused. It is simply an adjunct to getting people on their weight loss pathway and their weight loss journey in some respects, of which bariatric surgery essentially, for the vast majority of patients, well, for a significant proportion of patients, let me rephrase, is the end goal. So, so if you do sort of qualify for Saxenda, then that does not mean that you also won't qualify for bariatric surgery. So I wanted to simply clarify that, if that's all right. Just a couple of things. I'm just going through a couple of questions. So I think Samantha Hickling has asked, so if you're not diabetic, it is not an option. So that's not true. So as I said, essentially, if you are not diabetic, then it's not an option through your GP practice. However, I hope that with time, more patients with obesity alone can gain access to this treatment if they fit in nice criteria. So I can appreciate that it seems quite restrictive at the moment, and there is a particular reason to that. So as is the case, and as Jody mentioned previously, it is hoped that more patients will gain access to this in the coming years, essentially. So Julia Johnson has also asked, what if you are pre-diabetic? So again, the same sort of criteria applies. So unless you've been diagnosed with type 2 diabetes, then you can't get this treatment, or you can't get a sort of GLP-1 agonist essentially through your GP. Mr. Lawrenson has asked, is Trulicity a GLP-1 agonist? Yes, it is. So it's an alternative sort of treatment that is licensed for patients with type 2 diabetes alone. It also has got sort of an effect with regards to weight loss, but the drug on its own has not been studied for a sole obesity indication. So it's only available essentially for patients with type 2 diabetes currently. I think that's more or less it. So one more question about metformin and PCOS. So yes, Claire, so don't worry about that. I think that we will factor that in essentially to formulating if you are sort of eligible or not. So it's not only the HbA1c, there are other criteria as well, essentially, that a patient must fulfill prior to recommending this on the NHS at least. And finally, you are right, you can purchase this privately. I think that the cost is something that I can't really comment on per se, but it is sort of available through private prescriptions.
Yeah, can I just pick up some of the other questions?
Yeah, please.
There's just some around surgery and things. So somebody's asked, while I'm waiting for the first meeting with Salford Royal after being referred across, can they access the support of the Salford Royal physiology team, or are they sort of waiting for the surgery in their first appointment?
Yeah, so once you've been referred to us, you are waiting for that first appointment with us to then be registered and under our care and meeting our team. So essentially, you build up for surgery, knowing that you want surgery. Accessing psychology and the support in your weight management service is essential, because when you come into us, it's usually because you're discussing the surgery and which surgery would suit you. So beyond that, most of the care we're providing will be then after surgery. So yeah, this is definitely the time when you're considering if this is for you and wanting to be referred.
Perfect, thank you, Jodie. Beverly has asked, after surgery, do I have to have liquid versions of my medications, or can I just grind them down, as I usually take supplements and don't feel that the NHS should pay for them?
Okay, so that's a really good point. So with medications, we're really lucky. We have a lovely pharmacy team who will come and look at all your medications prior to on the day of your surgery, and then they'll let you know the ones that you need to go home with. When you first have your surgery, it's like weaning a newborn baby back to normal diet. So the less you have orally in terms of tablets, the better. Some can be liquid form, some can be crushed, and some less than a 5p piece can be taken whole. However, we will tell you which ones are essential for you to have in that first 3 weeks, which for me is when you're in the sort of healing period. And as I say, the priority is moving around and getting that oral intake of fluids up to around 1.5 litres a day. And then we build up from there. So from week 3, after being so careful and having everything like non-essential or liquids, then you can take all your tablets as normal, but it will be under the guidance of your GP as well, because a lot of those medications, hopefully as you go through your rapid weight loss, you may not need anymore. And there's lots of things around that which our pharmacists will go into in more of a talk. I won't give all the spoilers away because it is quite an in-depth presentation in itself. So yeah, so absolutely we'll have our pharmacist soon.
Perfect, thank you, Jodie. The next question is from Pauline, and she says, what age do you stop surgery? So I presume, is there like an age limit, or may she not be considered because of her age?
Do you want me to take this one? So we're not an ageist team at all, and there's sort of physiological age, which you know, we all age differently. We all go through different things in life, surgeries and other things that we may have, other conditions we may have. So all those things are taken into consideration. But no, we've done surgeries on people in their 70s, and that's been absolutely fine.
I agree. Yeah. So obviously, as such, it would make sense for you to have for a younger patient, essentially, or let me rephrase. So obviously, if you're able to treat obesity essentially at a younger age, you are much more likely to see the benefits of that, essentially, with regards to minimizing your long-term risk of obesity complications and so on. But as I said, from a surgery perspective, there isn't a typical age per se where we say, you know what, you can't have an operation. What we do find, however, is that the older you get, the more comorbidities and other illnesses that patients tend to accumulate, which may impact on their surgical risk, etc., and so on. So these issues need to be factored in when considering if a bariatric surgery as such is is a safe approach essentially for these patients, I think.
Thank you. The next question is, if you've already had a psychological review and you're waiting for your referral for bariatric surgery, will you have to have another psychological review when you move to tier 4?
Potentially, yeah. It's great if you have a service, and I think almost all services now have access to a psychologist. So any group interventions, anything that you offer with psychology, take on. You may think, oh, I don't really need this, but it's all for your benefit. And in the NHS, access to psychology is almost impossible, and it's something that's provided for you in this the service you're in now. So absolutely take advantage of that. When you come to meet our team, we look at things of surgical readiness, and that assessment can, again, like I was saying before, can be quite useful. So I sell them really, and some people ask for them because they just think, oh, actually no, it would be good for me just have that check-in and just see that I have kind of got that awareness and have got my mental toolkit kind of ready for surgery. So as I say, these are not things to sort of barriers for you to progress. They're just there to help, and sometimes for the team if it's useful for us as well, just to know that you've had that assessment and we feel that you're ready from a psychological perspective. So the answer is until we meet you as an individual, but the vast majority have a psychological assessment regardless of what they've had in their weight management service.
Thank you for that. The next question is, what if you have been diagnosed with sleep apnea? So I presume they're asking, will that affect whether they can have surgery or not?
No, so I can answer this. So obviously obstructive sleep apnea is seen as an obesity related complication. So we would normally recommend that you are treated with, for example, CPAP, for example, prior to your operation, or at least I'm sort of established on that, mainly because of the fact that we ask patients to bring in their machine with them to their surgery, given that it may impact essentially on their post-operative recovery and things like that. What we tend to see is that patients with obstructive, the issue of obstructive sleep apnea essentially tends to go away for a significant amount of people essentially after their surgery. So they find that they can come off their machine essentially literally in a matter of days to weeks essentially after their surgery. And it's as effective as that in some respects. So, and by all means, OSA is not a contraindication to surgery in any way.
And I've just seen a few comments that have just come on based on what you were just saying. So yeah, if you have any concerns and you have a sleep study test done, and you've been diagnosed with obstructive sleep apnea, and you may be trialed with something called CPAP, which is continuous positive air pressure, and this is while you're sleeping. So some people can't tolerate it, but if you can, what a difference it can make. So when you come along to things and they're saying, well, if you exercise more and do this, most of the time you just feel really tired, and it's very difficult to engage with things that you want to engage with. So quality of life can definitely be improved with CPAP. I noticed someone says they've just got their machine and they're already noticing the difference. You need to bring this machine with you to hospital. You absolutely use it while you're in the hospital, and there's clever little things in the casing that you probably don't know about. There's a filter that's quite useful, and there's essentially also a little oxygen adapter. So during the night, if for any reason, which sometimes we do after surgery, need to give you a little bit of oxygen, we would do that through your CPAP machine. So please bring those into hospital with you on the day of surgery.
Thanks, Jodie. The next question is around having a baby after surgery. So Zavine has said, can you have a baby after having a bariatric surgery, or can you not conceive again? I have type 2 diabetes and I'm overweight, but I'd like to have another child in the future. I don't know
Okay,
who wants to take that.
Yeah, no, I'm happy to take that. So yes, be careful and be warned. Your fertility can improve with weight loss. So we have had a few ladies that are still childbearing age, but perhaps weren't planning a family, get caught out. And maybe they get caught out for a few reasons. Maybe they've not had regular periods and they resume, making them more fertile. Maybe they're using an oral contraceptive pill, and because it's going through a sleeve or a bypass, we couldn't say to you, oh, that's definitely the 98% effectiveness that you had before surgery. We simply don't know that you're going to absorb it in exactly the same way to give you that contraceptive effect. So we do say after surgery, you should wait 12 to 24 months, ideally, to conceive and to use contraception during that time. Ideally, for a non-oral route, so that might be condoms, or it might be a Mirena coil, or the depot injection. But no, it significantly increases people's chances of conception if that's what you're having your weight loss for.
Thanks, Jodie. I think this question was kind of coming off when you were talking about the sleep app machine in hospital. Someone said, how long are you in hospital for after the surgery?
So we would plan for you to be in hospital. You come in on the day of surgery, hopefully go home the following afternoon, evening, because most of your recovery will be at home, and that's why you can't get rid of me then. I'll be phoning you the week after, having lots of phone calls strategically along the way, but you, from meeting our team, you'll have mine and the dietitian's number for any support or questions that you have. So you should go home the following evening. Sometimes you might stay in a night or two more. I saw something about the private provider before. So a private provider that we use, yes, they have slightly different criteria to Salford. We will operate on everyone that we've cleared as fit for surgery. Sometimes you might meet our anaesthetist first. We tend to ensure that people that have higher risk factors or more comorbidities are always done at our Salford Royal site, just simply because we have the benefit of the expertise of all the other teams that work with us, should we need them. So you tend to find at Salford Royal you might stay in for 2 nights, but ideally just 1. And then our private providers, again, it tends to be just the 1. There's reasons you might stay in a little bit longer. It's usually making sure we get on top of any pain management for you, making sure that you are tolerating fluids easily so that you can go home and safely recover, where you feel more in control and you've got access to your freezer with all your lovely pre-made broths and things.
Thank you. There's a lot of questions around BMI and surgery. So quite a few people have said, what's the highest BMI you'll do surgery on, or could that prevent them from being accepted for surgery?
Sure. So I think when it comes to peak BMI, I think it very much is a spectrum. So I don't think there is a particular body mass index per se where you will be declined from surgery. What we do know is that we would take patients certainly with a body mass index of above 55 or on sort of an individualized basis in some respects to see if they if it is going to be technically feasible essentially for a surgeon to operate on them. If the surgeon feels that they need to lose more weight in order to make surgery safer, or to ensure that they are at a threshold whereby they can have the right surgery for them, then there are things that we can do, for example, in order to help a patient to achieve that surgical BMI, as we call it. So our dietitians are excellent. So they work with patients very closely with the support of Jodie, who tends to coordinate it all. If they are eligible, for example, for a GLP-1 agonist, and they can have that. Some patients may also have something called a balloon, which is sort of a more technical procedure, essentially, which can be useful for some patients to get them to a sort of target body mass index to be able to have their surgery. So BMI alone is not technically a contraindication, but obviously for some patients who've got a sort of higher BMI per se, we may have to work with them in order to get to a particular sort of individualized target that will allow them to have the surgery that they need.
Thank you. I just noticed a question in the chat saying, is there any help afterwards for loose skin?
So I think that's a very good question. So I can absolutely appreciate that there can be concerns not only from sort of a cosmetic perspective, but also from a weight and body mass index perspective, because sort of excess skin can also contribute to a variety of factors post-operatively. At the moment, unfortunately, as such, there isn't NHS funding for surgery to treat excess skin post-operatively. So that's so people, or at least the patient, should be made aware of that.
Thank you. Another question has just come into the Q&A. So just to remind everyone, please put your questions in the Q&A, not the chat box. Can you ever eat normally again after surgery? I mean, as in a person who eats a normal amount, not someone who overeats. Or do you have to have tiny meals? Sorry.
It's very relative, isn't it, what you may think of as a tiny meal. So no, you're right there. So after surgery, you go through a phase of retraining your stomach back onto a normal diet. So I would expect you all to be able to hopefully tolerate steak, chips and salad, or be half a steak, maybe 4 chunkier chips and some salad, and that would be your meal. That would fill you up. You won't want any more than that, and you would always eat what I would describe as side plate portions for the rest of your days. I think we all know that there's so many factors that contribute to obesity, society being one of them, portion sizes being a huge one of them. These days, the portion sizes put towards all of us are much bigger. Even the children's portions in some restaurants are really too big for an adult. So we're sort of challenging the status quo on how food's presented to us, and the post-bariatric diet is probably ideal, given that we haven't evolved to cope with the amount of food that we're now presented with. So hopefully you will retrain your stomach around the 2-year stage after surgery. Things like hunger can come back. Your body can buffer some of the effects that are so wonderful early on, and at that stage you should have retrained yourself into new habits of a lifetime, because bariatric surgery is simply a tool that you're using, and you get this one opportunity with the NHS to have it. So we try and make sure that everybody's fully aware. So I know it can be frustrating, and it is a long journey for people that want weight loss surgery with the NHS. So it's just really trying to make sure that you make the most of the journey, and any weight you lose along the way with your tier 3 weight management, with the different things that you might be doing. You may already be part of something like Slimming World, which is great because it does help direct you into your kind of healthy lifestyle choices in terms of food and diet. Some of you may already have the t-shirt and you know all of that, and you're just weight maintaining because you're doing all the right things, but not a lot's digging into that weight now. So you're just hoping to have the bariatric surgery to give that kickstart to weight loss again, have that rapid weight loss in that first sort of 4 to 6 months, and then it slows down because it has to, and then maintain for the rest of your days with everything that you've kind of gone through on your journey. Someone else was saying, if I wanted to talk through my weight loss journey in a bit more of a personal way, depends which service you're with. If you've already been referred to surgery and already met your surgeon, then you'll have my number. And you'll have the dietitian's number. I'm afraid I can't talk to people, or people from our team can't really talk to anyone in a meaningful way other than through this forum. So if you're in the weight management service already, then speak to your service providers there. So depending which one you're under, whether it's ABL or Choose for Change, the teams there are wonderful, and we all do a sharing best practice so that you're all on kind of a fair and equitable pathway. So you should be able to talk to them as well about your pathway and the journey towards referral as well.
And just to add on to that, Jodie, someone said, how do we know if this is tier 3 or tier 4? So when it's tier 3, that's when you're with people like ABL or More Life, and then tier 4 is when you then have been referred for surgery and you're with the hospital team then. So just to clear that up, I hope that makes sense.
And there is that limbo in between when you're waiting. Some services are great and they kind of do like a monthly session where you can meet up. For others, this is it. You'll come into these sessions, checking in, hearing what the different members of the team have to say until you meet us at Salford.
Just to go back, someone asked a question, I think this is for Waseem, about the balloon. So they said, can we try out the balloon in the stomach before having the full surgery?
So I think it's a slightly tricky question for me to answer. So if you are first of all sort of eligible for bariatric surgery, if your surgeon feels that it is technically feasible for you to have the surgery that is going to be most beneficial for you, and there would not be much point in having a balloon first. So you might as well just go ahead and have your surgery essentially. In patients who surgeons think that, hold on a minute, they might have a body mass index or a body composition, for example, that may not allow the surgeon to perform the surgery of choice, then in those patients, sometimes a balloon can be considered, amongst other things, to try to get a patient to a specific target, which is usually individualized, to allow that patient to go ahead with sort of a sort of bariatric surgery in some respects. So I hope that makes things clearer.
Yeah, thank you, Waseem. Another question, sorry, going back to a previous topic, on conceiving. Someone's asked, what would happen if you do get pregnant in the following months or within a year of surgery?
Don't panic. A baby is a parasite. It will take everything it needs from you. But no, jesting aside, we like you to wait the 12 to 24 months, simply because then you'll be more nutritionally optimized. You'll have hopefully be just slowing down with your weight loss. But people do get pregnant in that time, and they go on to have natural childbirths, breastfeed, and do all the other things. But we would say within those 2 years that you do get in touch with us. And then we can help guide you and your obstetric team if they need any assistance, and just a few things that we would tweak. And there's certain things in pregnancy that we might need to switch out. For example, your one of the medications that we use to help reduce stomach acid, we would ask you to take the one that's more suitable for pregnancy. If you're thinking about conceiving, then you should add in folic acid and things like that as you're leading into that 12-month where you might decide to start trying for a baby. Your post-operative supplements are actually all fine to have, but again, we just want to be aware so we can support you. Very often with pregnancies, you tend to find that you eat little and often anyway because it's just really uncomfortable. The bigger you get, or if you're in the early stages and you have nausea and sometimes vomiting. So there's things that we just want to help you along the way with. So if you get pregnant, you just give us a ring.
Thanks, Jodie. Someone else has asked, I live in Grimsby. Would I have to go to Salford for the surgery if that's the decision I choose?
No, I'm afraid you can only go through your locally funded your locally funded bariatric service, and so you would just get referred to whichever that team might be. I think there was a question earlier because I'm aware that ABL have got some people over from, I think, Sheffield way, so the other side of the north, and they were saying, oh, has our surgery started yet? So the team actually came and did a talk, I think it was last month or maybe the month before, and they haven't been given the green light yet for their elective surgery to start. So you do need to speak to your service providers in their area to find out when that elective surgery is happening. They are smaller services, so hopefully their waiting list would be similar, even if they don't get to start their elective surgery till later in the year. But yeah, waiting, I'm afraid, is part of this now. So I think mentally adjusting your mindset to, well, it's not a case of if I'm having my surgery, once you've met our team and the funding's been approved and you're on those waiting lists, it can be tough, and that's why we try and keep these sessions going for everybody that's waiting, just so you can touch base and it's nice to see that some of you have already kind of got your own groups. A word of warning with social media is great for all of us until it isn't. So sometimes you need a break from that. Sometimes it can induce anxiety. Sometimes the advice you get is a bit challenging, and if you're not sure, then challenge it with the healthcare professionals, whether that be with the service you're in now, the weight management, or whether you've been referred to the surgeons and you've actually met them. So until you've met them, and then you can access us once you've met our team, and we can help with any questions you've got too.
And just to add on to that, I think it's Castle Hill that works with Grimsby clients. So just to clear things up, I think that's who you would be referred to when you are ready. The next question again, sorry, is going back to post-surgery. Is there a way to reduce excess skin while on this journey before surgery and after?
So before surgery, exercise is great, and if that's something that you can engage in, wonderful. After surgery, excess skin is almost inevitable. What's in our DNA and genetics will kind of dictate a little bit how excessive that is, or our initial BMI as well. So how high your BMI was and how much you lose. So I think it's something that everybody has to be aware that you will most likely have excess skin. I know I saw someone saying, oh, I've heard people are getting it after pregnancy and things like this. The only way that I'm aware of that you can get, and obviously I ask commissioners all the time what my bariatric surgeries patients can have. The only way that people get funding for NHS skin removal, and even then it's really difficult, is if there's another medical condition that's come about because of it, and there's more of an urgency to get that done because it's impacting on their health in another way. But excess skin in itself, unfortunately, is still not funded, and it's something that you would need to lobby your local councillors about, and keep raising the flag for these things, because we don't think it's right that this isn't something that's part of our service.
Thanks, Jodie. Now to sort of go back to the injections briefly, a couple more questions have come in. So someone's asked, what happens when you stop taking the injections? So after the 2 years, I think they're wondering what happens then.
Sure. So that is a very good question. So I'll answer it on sort of two fronts, if that's okay. So the sort of the real world studies that have been done only look at what happens with weight essentially whilst you're on the treatments. That's why they only follow up patients essentially for a certain duration when they are on treatment. What we don't know in terms of objective real world data is what happens to patients once they finish their injection. So what happens when they finish their initial 2-year course essentially. It is quite plausible that some people may regain some weight, and because if you were to think about how these injections work, they have an effect on suppressing appetite, etc., and so on and so forth. So it seems quite plausible that sort of calorie deficit and sort of intake essentially increases on a simple level when you're off the medications. What we don't know is if your weight goes back to baseline. So we don't have that information, and I mean certainly essentially it is something that we are looking into, but because these agents are quite new at this moment, we don't have the long-term data at this stage in order for me to answer this question as effectively as you would like. So the honest answer is we don't know. It is plausible that you might get some weight, but simply as such, we're waiting for the data to be published to be able to answer questions like this in a bit more detail.
Yeah, thank you, Waseem. I appreciate that was a bit of a difficult question. The next question, again, about the injections is, what are the risks, or are there any risks?
Sure. So as with any medications, essentially, there are always going to be side effects. So I'll talk about this in two ways. Number one, side effects. The vast majority of people essentially will experience some form of gastrointestinal side effects, especially as they start to increase the dose. So, and what we find, at least in our experience, is that if a patient reduces their caloric intake, then these symptoms are a lot more palatable and less intense. So that's one of the reasons as to why we simply suggest essentially calorie restriction sort of alongside this particular treatment. And some patients, and with regards to gastrointestinal side effects, it is usually a problem at the start and the initial phases of their treatment, so usually within the first 6 weeks or so. But if they're able to sort of keep on it, and if they're able to sort of keep going with the treatment, what normally tends to happen is that these symptoms start to reduce significantly or to go away entirely with longer use, essentially. In terms of the long-term risks, again, because these agents are relatively new and we only have data up to a certain point. So these studies essentially have only looked a few years down the line as opposed to 20 or 30 years down the line, if you know what I mean. So we still don't know as to what the long-term effects are. There, in the past, or at least some of the rare adverse effects includes inflammation of the pancreas, so something called pancreatitis, which can sometimes present with abdominal pain and other complications essentially of having a sort of malfunctioning pancreas. In the studies that have been performed, the vast majority of people who had a pancreatitis were mild. And some patients can also have gallstones, essentially, which can be precipitated essentially with these injections, and gallstones on its own can also cause pancreatitis. So these are some of the adverse effects. In the past, there have also been sort of considerations about the risk of thyroid cancer. So the jury is still out on whether this is in fact a true risk or not, essentially. The studies so far essentially don't appear to suggest this as a major risk. But again, we don't have the long-term data for these. So, 20, 30 years down the line in some respects. So these are usually as such the sort of the potentially more serious side effects of the medication that we tend to counsel patients on. But as I said, these are very rare. And in the vast majority of patients, the benefits of the treatment far outweigh the potential long-term risks.
Okay, so I think we've got time for a last question now. I appreciate lots of people need to go. That's absolutely fine. The sessions are usually around an hour and a half. We tend to take our last questions around now. So Grace, let's have our last question. Yeah, I think this is a good question to maybe round off on. Someone's asked, how can I access the previous sessions? And I haven't joined the Facebook group yet. So I've just shared, if you please have time, a satisfaction survey and the Facebook group. So please do feel free to join them. Previous sessions, every session is recorded. So if you do talk to your tier 3 provider, they should be able to provide you with the link of the edited version. Does anyone have anything to add to that? I think that sort of sums it up quite nicely. No, that's great. Thank you, Grace. Thanks everyone for coming.